Okay, so this is a chapter on, it says disorders of central and peripheral nervous systems and neuromuscular junction. What we're really going to talk about are traumatic brain injuries and related things, spinal cord injury, stroke, aneurysm, and some couple of demyelinating diseases. So to start with, CNS disorders, traumatic brain injury it's just what it sounds like. It's trauma that causes a brain injury. And what it does is it's going to, and I think you probably know this, but it's going to alter brain function. And the cause is by some kind of external force, so some kind of external trauma, like motor vehicle accidents, falls, um, those kinds of things, getting hit with a blunt object, whatever that may be. Um, so it can be primary, which means that whatever happened caused a direct impact, and that's going to be either focal, which means it's in a particular area, or it's diffuse, which means it spreads out a little more. Secondary can be an indirect consequence of some kind of a primary injury, so maybe there's a blood clot or some kind of seepage of fluid or something like that. Okay, so primary injury due to direct impact, diffuse axonal injury due to shearing and tearing. So we're talking about neurons when we talk about shearing and tearing. We're damaging neurons, we're killing neurons. Focal lesions of lacerations, contusion, so cutting, banging, so it's like a bruise, hemorrhage, which is it's bleeding out. So secondary injury due to swelling, infection, hypoxia, so that means a reduction in blood flow. They can be diffuse, they can be multifocal, which means they could happen in diffuse. Multifocal means it can happen in a number of different areas. Okay, so this can be related to concussion, infection, or hypoxic brain injury, lack of oxygen. So, and really, and maybe this needed to be up a little higher, but ischemia is the most common cause of these secondary injury. You lose blood flow, which leads to hypoxia. Okay. So we have mild injuries, which is something. So we see this, frequently. Probably many of us have experienced it, but not seen on an MRI. It's usually considered a mild concussion. There may be a momentary loss of consciousness, but really there are no long-term effects, and there really aren't any, long-lasting, at least, neurological signs or symptoms. Moderate head injury, there will be a very short local or short loss of consciousness. They will cause small hemorrhages, so there is some bleeding, some swelling of the brain, but it's not as serious, so it's more serious clearly than mild head injury. And a lot of these are kind of judgment calls, but we have some things to kind of rely on, some criteria. A severe head injury is much more serious, obviously, and that's going to lead to irreversible damage. So we may have reversible damage that happens with a moderate. Irreversible damage happens with a severe head injury, and that's going to be from usually extensive mechanical and secondary damage. So we can see this is just kind of a picture here showing the different ways this can happen, and you can see the brain kind of moving from the skull. And when that occurs, when the brain moves, it's supposed to be kind of attached, okay? Not necessarily attached, but you've got the dura, you've got these layers, and everything is supposed to be kind of in that area. Yeah, there's a fluid surrounding it, which allows some kind of cushioning, but when it's severe, then you're going to have the breakage or the shearing of these neurons, and that's going to and those neurons may not, well, they likely won't be able to recover. All right, so a concussion, so we already mentioned concussion. There are a couple of different kinds, but in general, a concussion is a transient neurogenic dysfunction caused by mechanical force to the brain. Okay, we kind of know what a concussion is. I think a lot of us do, and that's when you hit your head really hard to the point that it moves your brain a little bit inside your skull. It's generally, not always, but generally considered a mild head injury, resulting in microscopic changes in neurons and supporting brain tissue. So momentary interruption of brain function with or without the loss of consciousness, and you usually recover from that within 24 hours. However, there is something called post-concussion syndrome, which may last for weeks or months. People report having more frequent headaches, irritability, insomnia, poor concentration, and memory. People report not being able to remember certain things when they thought they could before, and they're unable to concentrate. Okay, so a couple of terms here: mild concussion, immediate but transitory, so that means it doesn't last very long. Clinical manifestations, usually confusion that lasts for a minute or several minutes, possibly with some amnesia, and usually that's amnesia of, you know, what happened the moments before or right after the event. So classic cerebral concussion, that's going to have a loss of consciousness, and again, usually for less than 6 hours, but that's still, you know, that's still a respectable amount of time and kind of scary, actually. So with amnesia, confusional state that may last for hours or days. So still considered a concussion, but it's more serious than a mild concussion, which is what most of us are familiar with. Most of us are familiar with a mild concussion. There can be a transient cessation of respiration, which kind of makes sense since the brain is kind of controlling that, and when there's that trauma, it can have an effect on that control. Okay, so complications of traumatic brain injury: seizures. Okay, so we've mentioned, when we were talking about seizures, we mentioned that there can be other causes, secondary seizures, and traumatic brain injury is one of them. So it can occur within days, up to 2 to 5 years post-injury. Now, this kind of makes sense since to prevent, I guess, a seizure, you have to have the right amount of excitation and inhibition. And so depending on the damage, if you've got some scar tissue in there, you can kind of imagine a situation where you have activation of neurons, but you may not have the inhibition, and if it happens, lines up just right, and I know I'm just kind of reaching here, but if it lines up just right, then you can see a situation where you have too much activation, and then that can just sort of spread out from there to cause a seizure. So the seizures, hyperexcitability state related to the injury and repair. So this would be the process of repairing. Maybe you put some neurons in that are causing that. Seizure prevention is initiated early with moderate to severe TBI. What that means is you want to treat it. Okay, so you want to give some inhibitory some inhibitory drugs that prevent seizure activity. Okay, so chronic traumatic encephalopathy. Now this is something that, well, there was a movie made on it, and this is repeated injury, so repeated concussion. So we generally used to think of concussions as nothing to worry about, but when they happen over and over, this damage seems to build up, for lack of a better word, but it's a progressive disease, and it causes, and this is kind of an important word here, dementia. Okay, so people start showing, you know, dementia, Alzheimer's like symptoms, and they kind of go a little nuts. And it's from this damage. It's not from, you know, it's not Alzheimer's disease, although it's very similar to it when you look at the brain post-mortem. It has these plaques and tangles, and so it's very similar, but it's caused from that repeated concussion. So sports injury, blast traumas, work-related head trauma. Okay, so another thing that you should know about related to traumatic brain injury is when you have some kind of blunt force trauma or something, that it can form something called a hematoma. Okay, so hema referring to blood, and then oma meaning a body. So the important thing, the way these are distinguished, and this is pretty important, if you know what the dura is, so there's the dura mater, which is this more thick coating. It feels almost like a thick but flexible plastic that kind of coats the brain and it's supposed to protect the brain, but it sits under the skull. It's not part of the skull. And so if you have a bleed that happens, so if you have this kind of when you sever arteries is what you do. So you have these meningeal arteries that are around here that are supposed to be, they're supposed to move into the brain and around the brain. But what happens is they can break and that area can fill up with blood. Okay, so it says blow to the temporal lobe, which can rupture these meningeal arteries. So you'll have rapid bleeding, and rapid's another important word to remember here. Rapid bleeding, unconsciousness may be followed by a brief lucid period before unconscious again. Okay, now I don't know exactly why that would take place. It's brain function, and that can be a little mysterious, even though I've actually studied it. So focal symptoms of ipsilateral pupil dilation, so that means that the same side or the cross sides, pupil dilation and contralateral hemiparesis, so that would be one-sided weakness. So that's outside the dura, and that's where the word epidural comes from, outside the dura. It's the same for, when you get an epidural painkiller. Subdural means it's under the dura, between the dura and the arachnoid space. Now, the interesting thing about that is that's where you have more veins, so blood returning to the sinus to leave the brain. And so what happens in this case is there's damage to those veins. Okay, so that's important. So damage to the veins connecting the cortex to the dural sinuses, so that's blood draining from the vein, and those can get sheared and severed. And then you have venous blood that's leaking out, but it's going to leak more slowly. Now, I think we can kind of imagine that. If you have arterial blood, it's going to build up pretty quickly. Venous blood is draining, it's under lower pressure, and so it's going to bleed more slowly. And what happens is that you have damage that can build up over time. And now the reason I'm stressing this is because this is something that can happen with brain injuries, and people will have something, they might call it a concussion, and then they send the patient home, and then the patient will, over time, like it says hours or days or weeks, this can build up, this blood can build up, and people can die from this. So it's really important that when someone has a head injury that they monitor themselves very carefully to recognize any subtle changes, and then get back as quick as possible if they do notice something like that. Okay, and then there's intracerebral. So this would be damage that happens within the brain, and that can be caused from trauma. Acute elevations in blood pressure, something that weakens vessels, and so a vessel breaks. And so these are all so most common in frontal or temporal lobes if traumatic. That's just because of the location. But you can see that all of these are bleeds, but in the case of the epidural, it's an artery bleeding out on the opposite side or outside of the dura. Subdural is under, which the name implies, and then intracerebral is within it. Okay, so spinal cord injuries can include fractures, dislocations, subluxation, which is a slight misalignment. So really anything that you can sort of imagine that can lead to or allow damage to happen to the spinal cord. Okay, so most injuries result from some combination of compressive, which means you get hit really hard on the head, or fall, which is what happened to this poor guy. So compressive, rotational, or bending movement. He's not stretching, he's damaging his spinal cord, I guess, in this case. I don't know, these are weird pictures. But you can see the damage to the vertebrae, which is, something to be concerned about, but really we're interested in the damage to the actual spinal cord. Okay, so it occurs with initial mechanical trauma and immediate tissue destruction. Okay, inadequate mobilization following an injury. So this means that somebody's in a car accident and they will put you on a spinal board just so rather than saying, oh yeah, just get up and walk it off. That's not what you want to do when you have any kind of neck or back pain after some kind of an accident. Okay. May occur in the absence of vertebral fracture or dislocation. Yeah, you don't have to fracture the vertebrae to damage the spinal cord, although that's common for those to kind of go together. So acute spinal cord injury in general, okay, is a sudden transection of the spinal cord that results in loss of motor, because we have to start thinking about what's going to happen here. So loss of motor, sensory, maybe reflex, autonomic, below the level of injury. So when you damage completely, especially if you damage the spinal cord, which doesn't always happen, then you can have the loss of motor, sensory, reflex, autonomic, which means your parasympathetic, sympathetic, and we'll get more into the details of that. Spinal cord shock. So regardless of the level of the lesion, it's going to cause below that area flaccid paralysis with loss of tendon reflexes, absence of somatic and visceral sensations. Basically, you're not going to have sensation and you're not going to have control. And that includes bowel and bladder function, sympathetic vasomotor tone, may result in hypotension, so that means that you're not going to be able to cause vasoconstriction below that area, which is going to could cause low blood pressure to happen. Okay, so spinal cord shock may last for hours, days, or weeks, which indicates that it doesn't last, that it's not permanent. So that means if somebody gets a spinal cord injury, they may experience spinal cord shock. They lose all sensation, all control below that area, but then they may gradually start to regain some of that control. Maybe not all of it, but some of it. Okay. So resolution of spinal shock, return of reflexes, that might be the first thing that you see. And then it's a matter of just monitoring to see what kind of functionality and sensation that returned. Okay, so the spinal cord injuries usually don't cause complete severing of the spinal cord. Usually there's some kind of damage to a part of the spinal cord, and that's really a really important thing to remember. And so if we look at the anatomy of the spinal cord, it's really just a bunch of tracts, okay? The white matter part of the spinal cord are just tracts that are taking things up to the brain, sensation up to the brain, and motor control down from the brain. So really it depends on where the injury takes place. If it's not complete, it depends on where it takes place as to what the symptoms are going to be. So what's going to be affected. So here we say motor information is carried primarily on the ventral side, so on the front. And so if you damage the front of the spinal cord, but not the back, then you may lose motor control, but not necessarily sensory. Okay, so sensory is carried primarily on the lateral and dorsal side of the spinal cord, so there's a difference. Now, we also have this situation where pain and temperature information crosses over immediately, but touch and proprioception crosses over in the brainstem. So we'll get into that. It's a Brown-Séquard syndrome, and I'll explain a little bit more of about that. But you can kind of almost see now that it kind of makes sense that if you have damage at a higher level, that it depends on whether or not the signal, or if you have, let's see, if you damage half of the spinal cord, like the right side or the left side, then it kind of depends on whether crossing over took place right away or whether it crosses over in the brainstem, because as to whether you lose pain and temperature or touch and proprioception. All right, so let's get into some of these, a few examples. So central cord syndrome is one of them that we'll talk about. Anterior cord syndrome, so central cord is the center. Anterior cord means that you've damaged the anterior part of the cord, and then the Brown-Séquard that I just mentioned. Okay, so central, let's talk about that first. So it just so happens that the fibers in the tract controlling the arms are located more centrally. Okay, so if you have especially a compression type of injury of the spinal cord, that you may damage the central area more than the outer areas. So what does that mean? If lower extremities are controlled more laterally or on the outside, and arms are controlled more centrally, that means if you damage the central area, you'll lose arm control, but you won't necessarily, you'll maintain some lower extremity control. Okay, so damage to the central gray or white matter of the spinal cord results in, and that's what we see, loss of motor function in the upper extremities, but minimal or no loss of function in the lower extremities. Okay. Now, this almost exclusively happens in the cervical spinal cord, which kind of makes sense because if it happens down in the lumbar area, you're not going to lose any upper, upper extremity. You're not going to have any upper extremity loss anyway. It's going to be at and below that level. Okay, so anterior cord syndrome. So now we're damaging the front part, the anterior part of the spinal cord. So the anterior 2/3 of the spinal cord, usually caused by infarction of the anterior spinal artery. Okay, so that's what causes that specificity in this case. So deficits would be loss of motor function. Okay, because the motor, all your motor tracts are going to be anterior. And maybe loss of pain and temperature sensation from damage to the lateral spinal thalamic tracts. Those are going up laterally. So you'll lose that, but the posterior is unaffected, which happens to carry position, vibration, and touch, and so those may not be affected, okay, in this particular case. So hopefully you kind of get the idea that it really depends on the type of damage. Now, Brown-Séquard's kind of an interesting one because, like I said before, crossing over, so if this is your spinal cord, you have pain and temp. I just wrote pain temp. So pain and temperature cross over right away. Okay, so I'm going to erase that. I'm going to just write pain. Okay, so pain is going to cross over right away. Okay. Meanwhile, touch, so that's light touch. It's carried in a different tract. Doesn't cross over until it gets up in the spinal cord, or I'm sorry, into the brainstem. Okay, sorry for the spinal cord also being red, but I didn't think about it. So that means that if you damage the spinal cord here, oops, nope, again, made the same mistake again, partial damage, so if you damage just half of it, then what happens is on this side you lose touch because it crosses over, it doesn't cross over right away. It moves up first and then crosses over, so you've lost touch, but look, your pain sensation is still okay on this side. Now on the opposite side, it's going to have the opposite effect. The touch is going to go up, and then the pain is going to cross over and then go up. Oops, wrong color. Okay, so hopefully you get the idea, even though I kind of messed up my colors here. And that's because of the tracts. It's because the tracts are carried differently, and in this case it's because the neurons cross over right away or they cross over later, and it depends on how that damage, the side of the damage where it takes place. Okay, so damage to the partial section of the anterior posterior cord, loss of voluntary motor control on the same side, so your motor control is going to cross over later, so you lose voluntary motor control, but your loss of pain and temperature control on the opposite side of the cord. All right, so complete spinal cord injury. So damage to upper motor neurons, spinal reflexes still work but no longer modulated by the brain. So damage to upper motor neurons. It kind of goes back to our upper and lower motor neurons that we discussed before. If you damage the upper motor neurons, you still have spinal reflexes because you still have you still have back and forth communication between the muscle and the spinal cord, and that reflex is still intact. So reflexes still work. Hypertonia, so your muscle tone will be maybe increased because your brain's not able to control it because that's cut off. Spastic paralysis, so damage to lower motor neuron cells in spinal reflex arcs are damaged. So that means you have, in that case, damaged the neurons that are going to the muscles. Okay, so that means that there's no innervation that can happen for the muscles, and so they are going to be flaccid. So you're going to have flaccid paralysis in that case. And really, you know, the way spinal nerves work is they're coming out and they're innervating a certain area. And this guy, this blue and purple and orange, whatever guy, sort of shows that as neurons move out from, you know, the thoracic areas, this might go to innervate the arms. And it really just sort of depends on where they come out. So any kind of damage is going to be related to those spinal nerves, or in some cases cranial nerves, but the spinal nerves are going to innervate certain areas. So if you have an injury in the neck, so the C1 through C4, then that kind of gets up into the brainstem area, and so that could damage your ability to breathe. So that's where diaphragm function is taking place, your inspiration, expiration. And so when that's damaged, yeah, you can imagine that what's being controlled there, the diaphragm, is going to be affected. So below the sacral, so the sacral area is what's controlling urination and bladder function, that detrusor muscle, and so you're going to lose control of that. Okay, C7 through T5, that's going to be more upper extremity and finger control. It says T6, so thoracic through the sacral, that's going to be more down here in your lumbar region. And so that's going to be your lower extremities, your trunk and your legs. Okay. So again, I mentioned this already, but sudden traumatic complete transection of spinal cord results in flaccid paralysis below the level of injury. So that's not quite as complicated. Okay, so there's this thing with people who have suffered from spinal cord injury called autonomic disruption. Okay. Actually, wait, no, that's autonomic dysreflexia. That's the next slide. So autonomic disruption can happen. It's kind of the same thing, but you can see that the way that your parasympathetic, your rest and digest, the neurons that come out of the brainstem or the spinal cord are mostly out of either the brainstem, way up high here, or down low in the sacral area. Okay, so notice that's parasympathetic, that's rest and digest. Those are the things that are going to increase digestive ability, motility, that kind of thing, and can slow the heart rate. Okay. The sympathetic, which is your fight or flight, on the other hand, those are more in the thoracic area, moving down a little bit into the lumbar area. Okay, so this difference makes a big difference in terms of spinal injury, because you can sort of imagine that just depending on where it is, you're going to have different effects on your sympathetic versus parasympathetic. Now, what I was kind of getting at earlier is that in autonomic, there's this thing called autonomic dysreflexia. And what occurs with autonomic dysreflexia is if we look at the thoracic area of the spinal cord, that's going to innervate so first of all, this is going to be controlled by the sympathetic nervous system. So this is going to be your GI system, and it's also going to include your adrenal gland. Okay, so this is sympathetic control. And so what can happen is if you have something, let's say something triggers a sympathetic type of response. A lot of times it's associated with like a full bladder or something like that triggers a sympathetic response. Then what happens is that you have a reflex arc okay, to your thoracic neurons, a reflex arc is going to then feed back, and it's going to cause vasoconstriction. That's what your sympathetic nervous system does. Your sympathetic nervous system causes vasoconstriction. Now, normally, if you have control, control over this area, which you would have if you have a normal functional spinal cord, then you could shut that down. You could say, okay, blood pressure is rising. We need to reduce this vasoconstriction. Okay. If you don't, if this is severed, then what can happen is that whatever triggered this sympathetic response to cause this vasoconstriction and an increase in blood pressure, okay, because vasoconstriction causes an increase in blood pressure, this release of adrenaline, this vasoconstriction of the vessels in the lower areas in the abdomen, whatever caused that can't be turned off because the brain is saying, whoa, 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 our blood pressure is getting really high, so you need to release the vasoconstriction down here, but it can't make it. Okay, it can't make it down there. So this can just kind of run away, and this vasoconstriction remains. Now, what the brain does have control over, and I'm going to go back to this slide, is it can say, wow, the blood pressure is high, got its attention, the blood pressure is high, so we're going to reduce the heart rate, okay, to try to fix that. So it's also trying to send a signal, down here to tell these guys to let go. So if we have an injury around, mid-cervical area or mid-thoracic area, if we have an injury there, that signal can't get down there. And so this autonomic signal, this vasoconstriction, this signal that's happening here, and this release of adrenaline is going to keep that vasoconstriction going. So even though the parasympathetic nervous system is fine because the damage is, well, down here, this guy's got a really long neck, then what happens is that it does have the ability to slow the heart. So let's just kind of read through this now. So sympathetic nervous system may have a reflex response if triggered by some kind of stimulus. A lot of times it is full bladder or rectum. Could be pain, even if it's not sensed by the patient. It could be some kind of a trigger that some kind of damage is happening. Whatever's causing it. Then this sympathetic nervous system is activated, and it causes the vasoconstriction. So neuronal damage above T6, so thoracic 6, means that the brain can't tell it to stop. Okay, so it's an exaggerated sympathetic reflex. It's going to cause a dangerous rise in blood pressure. Why? Because there's vasoconstriction. Okay, it's caused by a reflex, but it's vasoconstriction. The heart rate is slow, and why is that? Because the parasympathetic nervous system comes from above that and is able to tell the heart to slow down. Okay. And so it's trying to correct the hypertension. So it's trying to correct that, but it's not able to because of the vasoconstriction. Okay, so it's trying to lower the blood pressure, but it can't tell the sympathetic to stop the vasoconstriction. Okay, so pallor and goosebumps can also happen, but really the important part of this, and I'll just say it, is that you have a rise in blood pressure, but your heart rate is slow, bradycardia. It's just this feedback loop saying slow it down, slow it down, slow it down. Pressure is still too high. The brain's sending the signal down to stop the vasoconstriction, but it can't. Okay, and so this is another image showing the same thing, the control of the heart with the parasympathetic, and then this feedback, this reflexive feedback causing the vasoconstriction. Okay. So let's move on to disorders of the spine, and so we're going to talk about back pain now in general. And a lot of times back pain, not always, sometimes it's from muscle, but a lot of times it's damage to the spinal nerve roots, and the lower back tends to be the most susceptible place for this to happen, often due to compression of a nerve root by vertebrae or the vertebral disc. And we'll see some pictures of how that might happen. A range of causes. Most common injuries, age-related degenerative changes in the vertebral discs and facet joints. So that's degenerative. So sometimes the degenerative disorders of the spinal, of the vertebrae can happen, and that can cause that area to kind of close up and move around those spinal nerves that are coming out. Vertebrae and intervertebral joints. Back muscles and ligaments, I mentioned that. A lot of times it's not even nerve related necessarily. So disorders of the spinal nerve roots, so even infections and things like that can get in there and can cause damage. And then spinal stenosis and herniated discs. And we're going to talk about herniated discs as an example to kind of see how this happens. So back pain in general affects about 2/3 of the people in their lifetime, and really that's because of the way that we are, the way that we stand up, and so our lumbar vertebrae a lot of times are going to be affected because it's in a more bendy area, and so more damage and more deterioration can happen in that area. So maybe a manifestation of a more serious pathological process in some cases, not very often. Usually it's pretty straightforward, and it's damage to the root from degeneration of the spine or something like that. So red flags, gradual onset of pain. So this could be like, for instance, a growing tumor or something that is kind of creeping in that might need to be looked at. Okay, so that's a tough one though, because a lot of times back pain can kind of increase over time, but usually it's kind of up and down rather than gradual. So you may have more pain at one time and less at another time, depending on your level of exercise. But if it's a gradual onset, it could be something a little more nefarious, like a tumor. Age, younger than 20 or older than 55. Sometimes fractures can occur as the vertebrae weaken, and that could be the cause of pain, and that's something that needs to be paid attention to, especially in an older person that may be suffering from osteoporosis or something like that. They may have a fracture and not even really realize it. Thoracic pain could be something like an abdominal aneurysm. It may not be the spine at all. So that's something else to look at. A lot of times what we think is pain may not, or what we think is back pain may actually be originating from somewhere else. Fevers, chills, night sweats kind of indicates an infection. Weight loss could also indicate some other kind of a disease or disorder that's going on. Okay, so let's look at a herniated disc. So the disc is this area that's supposed to be kind of a cushioning area between the vertebrae, between the bones of the vertebrae. And there's this stuff inside called the nucleus pulposus. It's a pulp that's inside it, and that's supposed to stay inside it. But what can happen is this can rupture. Okay, so this area around it, this connective tissue that's supposed to be surrounding it and holding it in, can rupture, and that nucleus pulposus can move out of that. And when it does so, it kind of pushes out, and it pushes against the spinal nerve, and it can cause pain. And not only can it cause pain, but if it's severe enough and goes on long enough, or just in general, if it pushes on it in such a way that it can actually cause numbness as well as pain. So this pulp is squeezed out of place, herniates. Herniates just means it pushes through. The annulus fibrosus, causing irritation of the dorsal membrane and compression of the nerve root. Okay, so usually occurs, like I said, down in the lumbar spine. And the causes tend to be age, trauma, degeneration of the spine. Okay, so any of these things can kind of lead to this herniation, this movement out of this pulp that's supposed to be inside. So signs and symptoms localized to the area innervated by the compressed nerve root. Okay, so that nerve root is moving out, and it's going to innervate a region of the lower extremities if we're talking about the lumbar. Okay, so numbness, motor weakness can all happen. Okay, so how does it manifest? Which areas does it affect? Well, it depends on where those nerve roots go. And this guy's bending over because that's sort of how this this dermatome. If you've heard of a dermatome, it's where the spinal nerves innervate. So they move out from between the vertebrae, the spinal nerves do, and they innervate certain areas. And when you bend over, it's kind of set on this concept of, you know, that we were on all fours at one time and then sat upright. And so that's why you can kind of see that's how it sort of innervates those areas. So depending on the nerve root that's being compressed, you're going to have symptoms in different areas, and that's what this is showing. Now, I'm not concerned that you match the numbness or the pain with the particular nerve root, but this is how it can be traced back by looking at a graph like this and saying, okay, well, it must be, you know, the L4 or the L5 or whatever disc or vertebrae is affected. Okay, so numerous causes, but usually disc herniation or bulging. So sometimes that it doesn't herniate out, that pulp doesn't herniate out completely, but it pushes on the outer fibrous part of the disc, and that can again push against that spinal nerve root. Spinal stenosis, which is a narrowing, so where that nerve is supposed to come out, that can narrow, and that's caused by degeneration. And that's going to push on it. So herniation occurs in the lumbar regions where the weight is being supported and the flexibility is the greatest. Okay, so this is the dermatome and how we can sort of trace back that damage. Okay, so let's talk about strokes in general. Cerebrovascular disorders. Okay, cerebrovascular accidents, which are really typically referred to as stroke syndrome, is so stroke is where you have a blockage, so some kind of a clot. In strokes, it's at least right now we're talking about a clot going to the brain. Okay, so it's a leading cause, the leading cause of disability, third leading cause of death in the United States. These can be ischemic, which is a loss of blood flow, or it can be hemorrhagic, where you have a loss of blood, so it's sort of bleeding out in that area. So in general, it's associated with hypoperfusion, which means that you're not perfusing the cells, the neurons, beyond wherever this damage takes place, whether it's hemorrhagic, or in most cases it's ischemic, it's a clot. Okay, so we call it a brain attack. It's focal, which means it's happening in a certain area. So in this case, you can see the clot happened here, and it's cutting off blood supply to the areas beyond that. Okay, so one of the leading causes of morbidity and mortality in the United States. Risk factors, family history is a risk factor. Not necessarily saying it's genetic, but there is a family connection. It could be just hypertension, which is another cause of it. That could be part of the family history. It could be just weaker vessels. Well, it wouldn't be weaker vessels, but there could be a lot of things leading to that family history. So smoking, obesity, and overweight, high cholesterol, diabetes, kidney disease, all of these things can increase the risk of stroke. Higher incidence in men in the younger years, but women will catch up statistically after menopause and will suffer as many strokes. So African Americans have almost twice the risk of first-time strokes, heart disease with conditions that predispose to clot formations on the wall of the heart valve or leaflets. Now, let's pause on that for a second. And what that's saying is that if you have a cardiovascular disorder where you end up forming clots, usually that's from stasis of blood flow, blood's not flowing the way that it should, a damaged valve or something like that may cause clot formation, and those clots may then move, and one of the first places they go is through this carotid artery up to the brain. So if a clot breaks loose from the heart, it kind of makes sense that it can travel to the brain and cause a stroke. Okay, so let's talk about these types. Ischemic, remember ischemia, decreased blood flow, and that's the most common. 85 to 90%, 85 to 90% of strokes are from some kind of, usually a clot. Okay, so large vessel atherosclerotic, thrombotic, and arterial emboli. So thrombotic means that it's a thrombosis, which means that it's a clot. Okay. In this case, it's talking about atherosclerosis. Small vessel penetrating arteries, so that's going to be the arteries that are moving down into the brain. So we go from large vessel to smaller vessels, and then cardiogenic, that's clots that originate in the heart. Cryptogenic, we don't know. And then other are migraines, vessel dissection. There's a group of things where we can point to the cause and say, well, that's not very rare, or that's not very common, and that's only 5%. So really, mainly we're looking at we don't know what caused it, or it's something related to, well, it's kind of divided between these others. And I'm not really concerned about tripping you up on which one is the most common. So, you know, paying attention to these percentages isn't as important as just sort of understanding how they can present. Okay, so hemorrhagic, most frequently fatal. I mentioned that, or maybe I didn't, but it is the most frequently fatal. So that means that ischemic strokes will cause damage. You know, you have loss of facial movement a lot of times is what happens, or some kind of body movement, but it also affects you cognitively. However, hemorrhagic, spontaneous rupture of an intracerebral vessel resulting hemorrhage into brain tissue. Okay, so that's you wouldn't necessarily classify that as a broken aneurysm, but it is a spontaneous rupture, so it's similar. So what can cause that? Hypertension. Yeah, high blood pressure and aneurysm can cause it. Arteriovenous malformation. So that just means that your blood vessel is somehow compromised. Okay, so maybe it wasn't an aneurysm. We haven't talked about aneurysms, but we will. Or head injury, blood dyscrasia. So something amiss in the blood that's causing it. Okay, so ischemic stroke, a clot. So sometimes a blood clot doesn't lead to a stroke. Okay, so sometimes there can be a clot that forms and that clot goes away on its own. Okay, we call that a transient, which means it doesn't last very long. Ischemic attack. So it passes, it goes away. I don't know, brain angina, I've never heard it called that, but that's what the book says. So transient ischemic attacks, TIAs, it's caused by a clot, so same thing as an ischemic stroke. The only difference between an ischemic stroke and a TIA is that with TIA, the blockage is transient, it clears itself, and it lasts less than 5 minutes. When it's over, it usually causes no permanent injury. You usually can't even tell, looking at the brain, whether it or not it's happened. Okay, sometimes you can, but oftentimes you just can't even see that anything happened. The reason that we're concerned about them really is because if you have it, people with a history of TIAs or transient ischemic attacks will go on to have a stroke, which is right here, about a third of those people. But we know that it happens because of it. There's a brief neurological dysfunction, less than an hour. The damage that does occur, and even though it's not permanent, is something called a zona penumbra without central infarct. So what happens is that if you look at a certain, so this is your blood vessel, this is where the clot happens. So what happens is it sort of forms, you can see that it's sort of starting to cause damage in this area, okay? But it doesn't, so infarct means that there's actual damage and cell death that takes place, and that doesn't happen, okay? So with an actual stroke, what would happen is you would sort of start losing perfusion in this area, and then you would see actual tissue damage. Okay, that would then move out and cause more and more damage. So you want to clear that clot as quickly as you can. And the cause of that is usually atherosclerosis. And that's for TIAs. People with atherosclerosis tend to have them more frequently. Okay, so how do you diagnose it? Usually an MRI or a CAT scan, CT scan to determine if it's ischemic or hemorrhagic. And for treatment, reperfusion. Okay, so you want to get rid of the clot. So you give a clot buster, which is TPA, tissue plasminogen activator. So you give TPA, dissolves the clot, and then you monitor the damage, because if it's a stroke, then there's going to be some infarct, some damage, and that damage will continue, can continue even after the clot has been cleared, because you've spilled out. It's necrotic cell death. You've spilled out all the guts of the cells around it, and so that damage can continue for a little while. And then, so the faster you clear it, the more you minimize that damage. And with a hemorrhagic, really your only chances are surgery. Okay, so let's talk about aneurysms. So an intracranial, and so we're focusing here on the brain. So we mentioned here intracranial aneurysms. And even though aneurysms can also happen in the heart, although it's generally a dissection, which we'll talk about when we cover cardiovascular. But there are a couple of types of aneurysms that we're going to talk about. A saccular or a berry aneurysm, and it's called that because it looks like a berry. Okay? At least as far as I know, that's what I've always heard. It's called that because it looks like a berry, or it looks like a sac. And then fusiform are more tapered, and there's a reason for these structures that we'll see. Yeah, on this page. So what is an aneurysm? So an aneurysm is a local dilation or outpouching of a vessel wall. So here's a vessel. This bubble is not supposed to be here. But what's happened is it's kind of blown a bubble out of the side of it. It hasn't ruptured, and a ruptured aneurysm can that's what causes damage. That's what can cause death very, very quickly, is when that ruptures. So it's that outpouching or forming a bubble out here, and of the wall of the vessel, vessel wall or cardiac chamber wall of the vessel weakens and stretches. Okay, so that's what we're seeing. So fusiform, saccular, or berry aneurysms are the types we're talking about, but there's something else structurally about it. So I'm going to move down here and look at this picture and see we have several layers to the vessel wall. Now, if it doesn't damage those layers and it just happens to be pushing out in that area, then that's going to cause a fusiform aneurysm. Well, not necessarily a fusiform, sorry. That's going to cause something called a true aneurysm. Okay. A true aneurysm. A true aneurysm, I'll say it again. A true aneurysm is when that vessel wall has not been damaged. Okay, so there's no damage, it's just pushing out and the vessel is stretching out. A false aneurysm, and I don't know why they call them true and false, they're both aneurysms, but a false aneurysm is when there is damage to that inner wall. Okay, usually, let's see, dissection or tear in the wall, often from surgery or trauma. And that's going to, but this outer connective tissue on the outer part of the vessel is still intact. And so it pushes out and forms that bubble. But the big difference is with a true, the vessel wall is complete. Okay, it's not damaged. With a false aneurysm, there's a break in the vessel wall, and that's what's causing it to push out. Maybe it's called true and false because the false seem to be cheating. It's cheating because it's broken through that inner membrane, and that's what's causing it to causing the aneurysm. But they usually are. The false aneurysms are a lot of times more associated with a berry aneurysm, but it's not exclusive. It doesn't have to be. And then I have here a dissection, which we'll talk about when we cover cardiovascular. Okay, so what's the danger? Risk of rupture. Yeah, risk of rupture, hemorrhage, clot formations can happen because anytime you're interrupting blood flow, you have blood stasis, you have swirling, and that can cause a clot. Classified according to their cause, location, anatomic feature. So berry aneurysm looks like a berry. Fusiform is more tapered, so that's the form that it has. And again, common in the aorta, and the greatest threat to that also is rupture. Okay, so headache and migraines. We've all probably had headaches. I don't know that for a fact, but I have. Most of any headache I've ever had has been a tension headache, and that is the most common. Okay, tension headache. It's a lot of times it's caused from just tight muscles. Could be caused from some vasoconstriction, vasodilation, or probably vasodilation, but it's the most common. And it's self-limiting. It usually doesn't last. It's not an emergency situation. It's a headache, and so there isn't any lasting damage. Treatment is usually with NSAIDs, non-steroidal anti-inflammatories, or acetaminophen, which is related to NSAIDs but is not one. Okay, migraines are a little more interesting and troublesome and more of a medical concern. Now, I will say that there are headaches that are caused by brain damage, might be a tumor kind of thing. So there are other things that can cause headaches that are more serious, but in this case, we're talking about a tension headache, which is not. So just to kind of clarify that not all headaches should be ignored just because it's just a headache, because sometimes it can indicate something else. But a migraine is a familial episodic disorder whose marker is a headache and is defined as repeated, this sounds awful, repeated episodic headache lasting 4 to 72 hours. The headaches I've had haven't been pleasant. I can't imagine having a headache that lasts for 72 hours that has throbbing or pulsating pain, causing vomiting or diarrhea. Sorry, those things just sort of go together. Nausea, vomiting, diarrhea. Often causes nausea and vomiting, probably not diarrhea. Often have triggers that can be avoided. So I can't imagine having a headache so bad that it causes nausea and vomiting and lasts up to 72 hours. But that's what a migraine is. We don't really know the cause of migraines. There are some genetic possibilities. There are some, it's familial, so there's probably some kind of a genetic predisposition at least. And there have been some proteins that have been identified. But really it's, there's a vasodilation that happens because vasoconstrictors are used to treat it and can make it go away. So it's preceded by an aura, maybe preceded by an aura. I guess it's not always going to happen. And an aura, again, are sensory cues, in this case such as wavy lines, flashing lights, blurry vision. It's usually irritated by bright light more when you're having the migraine. So sometimes they have triggers that can be avoided, and a lot of people who have migraines recognize their triggers and can stay away from those sometimes, not always. It's usually women 25 to 55 years old and caused by a combination of multiple genetic and environmental factors. Okay, so that's a migraine. Sounds awful. I've never had one, don't want one. Multiple sclerosis. So now we're going to end this with a couple of demyelinating diseases. So the first one we're going to talk about and spend more time with, I think, is multiple sclerosis, MS. Okay, MS. So first of all, a little background. Myelin is something that increases the speed of neurotransmission. Okay, so without this, and you can see the myelin in these pictures here, it's a fatty substance that surrounds and insulates those nerves, so it causes, instead of just constant depolarization, repolarization, moving along fast but slow comparatively, what it does is it causes an arc to be formed that forms very quickly, moves to here, and then jumps. So it causes this jumping that just really increases the speed by a lot down the neuron. So we don't want to lose the myelin. The other thing that happens is when you lose this myelin and the myelin goes away, that the neuron a lot of times will die as well. Okay, because any damage that happens, it can't grow back, and so the nerve a lot of times is lost, the neuron. Okay, so there are a couple of things that make myelin. Oligodendrocytes. Oligodendrocytes make myelin in the CNS, in the central nervous system. Schwann cells make it in the peripheral nervous system. Okay, so anything outside peripheral nervous system is anything outside the brain and spinal cord. Multiple sclerosis obviously is a disease that causes the destruction of myelin. Okay, so this myelin coating goes away in the brain primarily, central nervous system. So because it primarily affects the oligodendrocytes, and the oligodendrocytes place the myelin in the CNS. So demyelinated or sclerotic, which means hardening, kind of, patches develop throughout the white matter of the central nervous system. So there's decreased conduction velocity, because that's what the myelin does, and a conduction block, because a lot of times it's not able to go just because of the way the neuron is, without kind of going over how that all works again. Sometimes if you don't have the myelin, then that nerve signal just dies and it doesn't make it to the end. Okay, so this is important. It's autoimmune. It's not just autoimmune, but it's a type 4 hypersensitivity primarily. And so that's T cell demyelination. So it's an autoimmune mechanism that targets myelin producing cells, that targets myelin producing cells, and perhaps myelin proteins themselves. Okay, so it kills the cells, it kills the myelin that's being produced. That's what it's presumed to be attacking. So T-cell mediated demyelination of nerve fibers in the white matter of the brain and spinal cord, and this is showing the sclerotic plaques that we've seen. Okay, so that's what we're kind of seeing here. It's non-functional and it's harder, it's more stiff. Okay. So characterized by the formation of sclerotic plaques as seen on the MRI, and those can be looked at. So you can have an MRI and you can look at that, and you can kind of monitor the progress of it by looking at these sclerotic plaques. Results in conduction abnormalities. Yeah, that makes sense because we're talking about myelin. Symptoms may vary depending on the location and the extent of lesions. Okay, again, it's not really with some of the diseases we've talked about, they start in a certain area. Myelin, or the MS, doesn't necessarily do that, although it does have some favorite symptoms. Optic neuritis with visual field changes. So eyes can be affected early, speech and swallowing issues, and these are more critical. Speech and swallowing can be a little more, I guess, a more serious type of symptom. Muscle strength in terms of, especially with swallowing, you have to be able to swallow to eat. Muscle strength, gait and coordination, balance, eye movement, those can all be affected. So this is MS. It's autoimmune. Things to remember: it's autoimmune and it's central nervous system. Now, let's look at another demyelinating disease called Guillain-Barré syndrome. It is immune-mediated demyelination, but in the case of Guillain-Barré, it's peripheral. Okay? So this is a peripheral disorder. Remember, MS was CNS, central nervous system. It's acute. Okay? So that means that it comes on very quickly. And so it's an acute inflammatory polyneuropathy. So it's affecting a number of different neurons. And the cause is really unknown. The cause is unknown, that's for sure. But 2/3 of the cases follow an acute viral infection. So this is where the immune system is fighting off a virus, producing antibodies. Okay, so it's producing antibodies, and these antibodies somehow start attacking the Schwann cells, the myelin that's being, the Schwann cells lay down the myelin in such a way where it's actually attacking the Schwann cells, and the myelin is being removed. Okay, so really that's probably what's happening in, at least we know most of the cases, 2/3 of the cases, is that it's antibodies that are being formed against a virus, but then those antibodies go on likely to to attack the myelin. So it's supposed to be attacking the virus. So really what happens is that as these antibodies start to go away, then so do the symptoms of the Guillain-Barré syndrome. Okay, so it's characterized by rapid, progressive, ascending paralysis. Okay, ascending paralysis means that it starts at the distal areas, like in your toes or something like that, hands and feet, and then it moves toward your spinal cord. Okay, so that's the progressive and ascending paralysis. So no cure, but resolution may progress in a descending order. So it progresses in the opposite, or it resolves in the opposite direction than it started. Now, one thing to do is if you have an autoimmune or an immune-mediated disease that's directed by antibodies is to get rid of the antibodies. Okay, so you do plasmapheresis, you remove the plasma that has the antibodies in it, and then you replace it with donor plasma that doesn't have the antibodies in it. It's really pretty that straightforward. You just kind of swap out the plasma, and that will at least slow down, probably stop the damage. Usually presents as a medical emergency. The treatment initially is, of course, support vital functions. Don't let them die. And then swap out that plasma with plasmapheresis. So autonomic nerves are also affected, so blood pressure changes, tachycardia are often seen, so that's where it becomes emergent, is when you see cardiovascular issues. EMG or electromyography can detect the slowing of nerve impulses. That's measuring the electrical impulses of the muscle. Okay. So the last thing we're going to talk about are neuromuscular junction problems. So we kind of know what the neuromuscular junction is, and we should have learned that in physiology. And what happens is you release acetylcholine. Acetylcholine moves across the synapse and then binds to acetylcholine receptors on the other side. Okay, so a number of things can affect this. Botulinum toxin, for instance, decreases the release of acetylcholine. Okay, so that's why botulinum can, Botox can numb, or not numb, but can stop muscle contractions, which reduces wrinkles, I guess, but it can also kill you. Botulinum toxin can. It's very deadly. I guess it just depends on which muscles you're shutting down. So decreased acetylcholine effects on the muscle cell. So there are certain drugs, poison darts, curare is a poison dart that blocks the receptors and doesn't let the acetylcholine bind. And then what we're going to talk about is myasthenia gravis, which kills off or attacks, it's autoimmune also, attacks these receptors. Okay, so the way that acetylcholine is cleared is with something called acetylcholinesterase. And acetylcholinesterase gets rid of the acetylcholine. So if we block acetylcholinesterase, then what happens is we end up leaving that acetylcholine in there for a longer period of time. So all of these things kind of work together. We're mainly interested in the myasthenia gravis, but that's just kind of the way that this works, and some examples of what some of the effects that can happen. So with that review, we're going to talk about myasthenia gravis. It's an autoimmune disease. Okay, and it causes gradual destruction of acetylcholine receptors. Okay, so it's complement mediated. It's really IgG antibodies that are tagging these receptors, and then they're being destroyed by the autoantibodies or complement and removed. Okay, so that's the way it's happening. It's really going to be a type 2 in that case. It's hypersensitivity, and yeah. So you remove that. The acetylcholine receptors don't survive, or at least some of them. It's taking them out a little bit. And certain muscles or certain motor neurons aren't going to be able to activate the muscle regions that they're trying to activate, and so that's going to be perceived as weakness. Okay, muscle weakness, fatigue, you just aren't going to be able to perform. The muscle performance isn't going to be as much. So it's the opposite of Guillain-Barré. It moves from proximal to distal. Often eye movement is affected first, which is diplopia, and that is crossed eyes. Okay, I don't remember that all the time, but that's what diplopia is, crossed eyes. Which kind of makes sense because the eyes are trying to kind of keep everything focused in one area, and if you have loss of muscle strength, then that means that one of those eyes can sort of move off to the side. Okay, so that's an indicator. Difficulty swallowing, again, muscle control weakness, so that's going to, you expect to swallow in a certain way and it's not going to happen. And then myasthenia gravis, myasthenia crisis or cholinergic crisis can happen because acetylcholine receptors are sort of needed for autonomic functionality. The autonomic nervous system does use acetylcholine. Okay, so acetylcholine is involved, and so what can happen is myasthenia crisis, which is your respiration may be compromised, and it responds to anticholinesterase. The disease itself responds to anticholinesterase drugs. Okay, so if you block acetylcholinesterase, so that's how you're going to treat it. You don't have enough activation of the neurons. So the idea is that you try to leave that acetylcholine in the synapse for as long as you can, and you do that by blocking the enzyme that's breaking down acetylcholine, which is cholinesterase. Acetylcholinesterase. And so, but that's it. Hopefully that kind of makes sense. So, and I think that's the last slide for this section, and it's a lot longer than I want it to be.